Hello and welcome to the third and final video in the series of 3 on motivational interviewing in patient care for ND Counseling 3. Before we begin, I want to emphasize that in no way is this an exhaustive coverage of the field of motivational interviewing. Much can be learned from books, from videos that are free and easily accessible already on the web, and from seminars the Public Health Department puts on several motivational interviewing seminars throughout the year, and those are excellent to attend as well if you wanted to go deeper into this approach of motivational interviewing. With that said, let's begin. I love this quote by Tolstoy that says, "Everyone thinks of changing the world, but no one thinks of changing himself." When it comes to our patients in motivational interviewing, I would say that they do think of changing themselves. They simply are lost in how to do so. And we, by acting as guides and coaches, walk with them in this process of change. So for this session, our objective is to really explore the types of statements and types of words our patients use. By identifying their type of talk, DARN talk, change talk, we can support self-efficacy and increase confidence and motivation for change. Because this cannot be emphasized enough. Pre-contemplative, contemplative, preparation, action, maintenance, relapse. Learn these. Please keep in mind, for one patient with a particular issue, there can be multiple stages of change regarding the behavior. A patient with hypertension, they could be in pre-contemplative stage regarding diet. They might not know that certain aspects of diet could influence blood pressure. They could be in the contemplative stage regarding their blood pressure medication and supplementation. They might say, yes, I know that this is something that I don't like. I would like to change my medication. I'm having trouble with that. And they could be in the preparation stage regarding breathing exercises. They've done it in the office. They've seen that it's lowered their blood pressure. They're just working on creating a plan for continually practicing those breathing exercises. And they could be in action phase regarding exercise. They've been doing it for a while now. So one patient, a particular diagnosis or problem, multiple behaviors, different stages of change. What are we going to cover here today? We reviewed these key principles or strategies in motivational interviewing, clarifying contracts, for instance, remembering that's setting an agenda, asking the patient, what are we going to talk about today? To engage in their worldview, to know where we're going. We express empathy always, as we've already talked about, with warmth, empathy, and genuineness, and regarding our ORS talks. Open-ended questions, affirmations, reflections, and summaries. We already spent time talking about developing discrepancies. Avoid argumentation is simply that principle that I mentioned before. If you start to argue for change, the person will become more entrenched. Draw the line in the sand. Now, if you have them argue for the opposite, the thing that they want to do, that could help. But the main principle is we don't want to argue with our patients. And rolling with resistance, and we're going to be talking about self-efficacy today in identifying parts of change. The key point to remember is that patients are ready when they want to change. They believe it's importance and confidence, and they're able to change, the confidence piece. So readiness is based on that, and that is part of self-efficacy. The other thing I'd like to stress is how we feel about the patient's ability to change can become a self-fulfilling prophecy, as I've mentioned before. Notice when your biases about a patient's ability to change, whether they have the resources, you think they don't have the resources, whether they don't have the mental capacity, whether you think they just don't have the interest. check those out. When we empower patients, we see them as an equal, and we explore our own biases. Check them out with the patient. Treating them as an adult and as an equal means we have those dialogues. Last time we talked about building intrinsic motivation for change by looking at, identifying, calling to light the ambivalence. Today we're going to talk about strengthening the commitment for change by identifying the type of language our patient uses. So as we listen to our patients, we can really break down their statements into about 4 types. Now, this is not 4 types of change talk. This is just 4 types of motivational statements: cognitive, affective, intention, and optimism. The cognitive recognition, it means they already are mentally thinking about their change. I guess my hypertension is affecting my overall health. It's a thought. It's not necessarily talking about how they respond to it emotionally or affectively. Affective expressions, I'm worried about my blood pressure. The intention to change can be direct or implicit. It could be the direct idea of like, I need to do something now. Okay, I have to do something now. And then there is optimism about the change. And I will probably use this statement again. My patient said the other day, if I can change my breathing here in the office, I must be able to do it when I'm talking to my boss. And that's speaking about what they think they can do, their ability and their optimism to do this. So notice when our patients are talking about their thought, their affect, their intention, or optimism. The important part is the cognitive and affective one, in that many times we respond to cognition when the person's really talking about their fear. So notice if you can identify the difference between thought and feeling. So, how do we help evoke change talk? And we do it by identifying DARN, DARN-C. The C is on the next page. DARN is an acronym for desire, ability, reason, and need. And it's really helpful to notice this. Desire is when the person is talking about what they want to do, hope to do. It's made about their preferences for change. We can hear this when the patient simply says things like, I would like to, I wish to. I really want to, whatever, eat better, stop smoking, weigh less, do my breathing exercises. It's what their preferences are. Again, the ability now is about their self-capacity. And you'll hear things like, oh, I think I could walk around Green Lake a few times a week. I could skip eating ice cream before bed. I might be able to take the stairs when I'm at work. We evoke those kinds of questions when we say, what makes you believe you can do this now? I think I can. We're asking about their ability, not their wishes. Now, reasons and needs are very similar. Reasons are about their arguments for change. For what reason do you want to make this change now? And you'll hear things, well, I know I would have more energy if I exercise. That's the reason. I know my blood pressure would go down if I could practice breathing and get off my medications. I know I would not have sinusitis if I eat cheese and milk. Those are the reasons. The need is about obligation, and we hear this often in the clinic with our should statements. Well, I should meditate every morning before work. Because? And then we often get to reason. I should stop drinking coffee. I should get off these meds. They're making me gain weight. So we hear the difference between desire, ability, reason, and need, and our questions can stimulate that kind of talk. For what purpose might you make this change now? Can speak to the need. What are your reasons? What makes you believe you can do this? What do you want to do about this behavior? The C is about commitment. And these are statements about the action to take change. So what are you willing to do now? I can blank. I will blank. I will do my breathing every day. So we ask some of these questions to evoke this idea about the behavior and where they are in the plan of change. And this can elicit this change talk, and we can expand on that. Desire, ability, reason, need, commitment. When we're talking about change talk, we get into this aspect of 4 types of change talk. And really to hear where they are in the process. We elicit this type of change talk because it's a guide to resolving the ambivalence. And so when the patient can talk about the advantages and disadvantages, they're more likely to make a change when they've thought about these. We have disadvantages of maintaining status quo, advantages of change, optimism about change, and intention to change. Very similar to what we talked about the first time. Just to remember, disadvantages of maintaining status quo or the reasons why they're upset about how things are. And it really reflects an understanding of the undesirable aspects of their personal state of behavior right now. If you keep doing this, what's the negative aspects of this? When I hold my breath and tighten, I can feel my blood pressure rise, my muscle tighten, and I have these damn headaches at the end of the day. What's the disadvantages of continuing to breathe the way you do? I get headaches at the end of the day. What's the advantages of change? Advantages of change is recognizing the potential for the benefits of the change. What are the good things that can be gained? I would love to make it through the day without needing ibuprofen or my blood pressure medication. If I did this breathing, this is what happened. I would need less medications. I wouldn't have headaches. Now, optimism of change is where we start to look at their confidence and hope about their ability to change. As I said earlier, if I can do it in here, I must be able to do it on my own. I must be able to do it when I'm standing in front of my boss. Some of our patients will say, I can do it in here, but damn it, I can't do it outside. Little optimism for change. And intention to change is talking about their willingness and commitment to a plan to change. I think I could do it at least 10 minutes a day in the morning when I get up, and then maybe in bed while I'm trying to fall asleep. I think I could. That's not just the optimism. That's saying I'm ready to start to put that out there. So we have listening to the disadvantages, advantages, optimism, and intention. Some more about disadvantages of the change talk. As I said, we're looking to support this. If they can hear what are all the problems, then they can recognize that this behavior is not useful for them. Again, we're not trying to convince them to change. We're just looking at all aspects of their worldview. Some of the questions we can ask to elicit this type of change talk is simply things that I've taken from Miller and Rolnick's book, Motivational Interviewing. What worries you about your current situation? What makes you think you need to do something about your blood pressure now? What difficulties have you had with blood pressure medication, ibuprofen? Is there something about your current situation that you or other people might find reasons for concern? In what ways does this issue with blood pressure concern you? How has your blood pressure stopped you from doing what you want to do in life? And another question I like, the final one, is what do you think will happen if you don't change anything? So these are ways to evoke disadvantages of status quo change talk. Advantages of status quo, again, is recognizing the positive things that will happen when you make the change. Here's some examples here. Examples of evocative questions. How would you like things to be different? What would be the positive things about lowering your blood pressure? What would be the positive things about breathing? One of the questions I ask my patients in their intake form is, how would you like your life to be 6 months, 1 year, and 5 years from now? If you could make this change instantly, how would things be better for you? And of course, the very simple question is, what are the advantages of changing today? So these are some evocative questions for advantages of change talk. In optimism of change talk, again, we're looking at their confidence and hope about their ability. And the main issue here is that change is possible. People can use change talk, optimism about change, in the hypothetical, I could do this, or the declarative, I can. Really notice that when they're saying I can, they're really on their way. So what are examples to elicit optimism of change talk? Quite simply, what makes you think you could make this change now if you decided to? What encourages you that you can change if you want to? A simple question, what do you think would work for you if you decided to change? What worked in the past? When else in your life have you made major changes like this? And how did you do it? That reminds them that they have the capacity. The confidence scale, how confident are you that you can make this change talk, is about optimism. To remember to support personal resources. What personal strengths, resources do you have that will help you succeed? Everyone does. And about the external resources, who could offer you helpful support in making this change? It's really important to look at our resources, our own personal strengths, and to remind people that they have them. And also important to notice that no man is an island, no woman is an island. We don't do these things in isolation. Change often happens with support. So who could help you in making this change? I've often told my patients who are trying to quit smoking that unless they tell everyone, I've often seen them not succeed. Now, I have to be careful when I would make such a bold statement because I don't want to discourage them. However, I do find that when people say, I'm telling everyone, I'm telling my friends I'm going to do it now, and they're going to all help me, that usually is optimism for change because they're not feeling the guilt, the shoulds if I fail. Sometimes they do relapse, or they're not in the relapse phase, but they'll do. They do stumble and they'll take a cigarette now and then. And then they say, wow, and this is how I got back on the non-smoking wagon. Who else can offer support? An intention to change, as I said, expresses directly or indirectly how they want things to be and when they're ready. Questions to evoke this kind of change talk is usually, what do you think you might do? How important? It's the importance scale on that importance confidence level. How important is this to you? How much do you want to do this? What would you be willing to try? Of all the options you presented, because the patient will often present them, all the things you could do, and this is with treatment plan, remember, all the options you've mentioned, what one sounds like it fits best for you? If you're using motivational interviewing when you're doing patient care and you come up with a myriad of options for the patient, breathing, dietary change, exercise, supplements, rather than prescribe them, we show them as a menu of options and you say, what one fits best for you? Another question that Miller and Rolnick talk about is, never mind the how for right now. What do you want to have happen? And how do you intend to do this? These are all ways of stimulating and evoking change talk about the intention. As I've mentioned before, we have problems when our core values are not aligned to the behavior. So throughout this whole part of change talk, we still remind the patient of their core values. Have them discuss that so that they can see the dissonance. We're still working with dissonance at times and ambivalence. And we just come back to the core values to support that. So we hear these different levels of change talk: disadvantages, advantages, optimism, and intention. And we want to create a change plan. I really would like to stress to you that we do not, in motivational interviewing, go out with our supervising doctor, meet them, come up with all these options, and come into the room with a treatment plan, say, do this, 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 and this. This is not the spirit of motivational interviewing whatsoever. We come in with a menu of options. These are things we find helpful. And that's what we do in motivational interviewing. We do say, hey, this is my expertise. From our work, this is what we see useful for this issue. Now, what do you want to do about that? Otherwise, we overwhelm the patient. Before we even go out to talk to our supervising doctor, we have to talk about summarizing their arguments for change. I hear you really want to change your blood pressure. And it's important to you because of this. This is what your disadvantages, your advantages, your optimism is. So let's summarize your reasons and needs. Those are your arguments for change, your desire, your ability. What do you think you will do now? What will work for you now? When I talk to my supervisor, we can talk about diet, we can talk about homeopathy, we can talk about physical medicine. Or you can be specific. This is the physical medicine shift. So we usually talk about exercises and physical medicine techniques. What do you think you would like to do now? On the biofeedback shift, we say, wow, we talk about breathing, we do meditations, and research shows people get benefit when they do it 20 minutes twice a day. What do you think you can do now of what we covered in this session today? We do this, then we can proceed to setting goals. We set goals and we consider the options for the change. That's when we create the plan. So the setting goals is we want to lower blood pressure. We want to start practicing things to help lower our blood pressure. Now here's the options. We could breathe this way, we could breathe that way, we could breathe that way. And then we create the plan. We elicit commitment to the plan. Usually when they create the plan, they get more commitment. We support that and we adapt it as necessary. We'll go into these. When we're going through change talk, we want to continue to support their confidence, to remind them that they can do these things. We elaborate the things that they say. This is already discussed in the empathy section. We elaborate, we reflect, summarize, affirm without being a cheerleader. And we also address possible problems and challenges. And this is important. When a patient says, yes, I can do my breathing, we want to raise the possible problems and challenges. Only by pointing them out are they more equipped to handle them. What are you going to do when you wake up and realize you have so much to do or you're late for work? When are you going to do your breathing? Or if you're talking to me about quitting smoking, as I've heard many times, what are you going to do when you're really stressed and wanting that cigarette? How are you going to handle this? This is where the resources come into play. Wow, when I'm really, really craving a cigarette, I'll call my friend. When I'm really craving a cigarette, I will do some of those breathing techniques that you mentioned. I had a few patients for a while who said that when I want a cigarette, can I text you? So they were supposed to text me, and they couldn't have a cigarette until I texted them back. Several times I got their texts, and I was free at the moment. I just didn't text them back. Sometimes I did and said, is this what you really want to do? Do you remember that you mentioned these things? Do you remember that? Not try that. Do you remember that? What's happening now? How are you feeling about telling me you want a cigarette? Many times the issue, I think almost all the times, the issue's changed. The desire changed just from that mere pause. So what are the problems and challenges? And it gets to what are you going to do about it. This supports confidence. If they say what they're going to do when they're faced with a challenge, they're more likely to do it. And this just goes over what we just mentioned: elaborate, reflect, summarize, affirm. Identifying the possible challenges. What might you do when you're jonesing for that cigarette? How could you respond if you're really stressed? What do you think would happen if your boss started to yell at you? What would you think would happen if you go to that party and you're surrounded by chocolate cake? This just covers some of the things we've already talked about: eliciting confidence to talk for change talk. We ask those evocative questions that I mentioned, and we use confidence rulers. We review past successes. What have you done that has worked? What has worked? Even if you did it only for 6 months, 3 months, what has worked? I remind patients that they would not be sitting before me if they had no success in life. And sometimes that's the session. We explore what actually did they do. Where did they stand up for themselves when they felt that they couldn't? They had to have. They wouldn't be alive. That means we explore their personal strengths and their resources, support network. This could also be support of other resources, like when I'm stressed, I listen to certain music. That's a resource for me. Nature is a resource for me. A bath is a resource for me. And we brainstorm how change may occur and can boost their self-efficacy. We reframe relapses. When people start to stumble, we reframe them. And we're not talking about a full-blown relapse that's at the end of the stages of change. You're trying to quit smoking and you have a cigarette. Or you're trying to breathe every day and you miss 3 days in a row. How do you frame that? One of the things I like to talk to patients about is in making a change plan is like doing a research experiment. If we use them in very small doses, we do a research experiment per week. This week, let's explore breathing 5 out of 7 days a week. Let's see what comes up. Whatever comes up, we get excited. That's one instant reframe we as providers can do. The patient says, I ate a pint of ice cream last night. What flavor? We reframe the guilt. Was it enjoyable? Yeah, I'm sure it was enjoyable. What did it do for you? Isn't that interesting? Let's look at that, so that we can find new things to replace that behavior if you want. And this is also giving information, not advice. I'm sorry, it says advice. Giving information, not advice. We do docere. We provide information and we allow them to take the lead there. How does that sound to you? So finally, to recap, in each stage of change, there's specific issues and skills that the practitioner needs to use. So in pre-contemplative stage, I don't think breathing and breath work has anything to do with my blood pressure. You're done. You raise doubts. Now you can raise doubts by saying, hey, can we try this simple exercise? Let's just see how this goes. And so you might try that. You ask them invitationally, can we do this? And they can say no. And then you do the breathing exercise, and they'll say, wow, I do feel different. That raises doubts for them. I'm not doing that to try to convince them. I'm presenting more information. They might not want to do it. The goal in pre-contemplative stage is raise doubts. You raise doubts. You don't start to argue. You raise the doubts. If that doesn't happen, you move on. Something else in your session. The issues for contemplative and pre-contemplative stage are similar. In this stage, there's still ambivalence. It's still present. So we continue to use our pro and con list in our decisional balancing process. What our goals are here is to assess the strength of commitment, and we do so by talking about the pros and cons and listening for change talk. We examine the barriers to change, what's getting in the way, and try to discuss solutions. And we want to build coping behaviors. So key questions for both contemplative and preparation stage. What do you think you will do? What's the next step? It sounds like things can't stay the way they are. What are you going to do now? So there are elements of the change plan We're looking at specific statements of change. Is it desirability, reason, need? And what are their reasons to change? And to talk about the stepwise fashion for making those changes by identifying the resources, evaluating that plan, and saying, hey, let's look at this again in a week. In the action stage, we're ready to commit to a plan. We're ready to commit to a plan, and we realize that it's a sustained effort. And ambivalence and commitment are still issues here. So we may have to visit and reevaluate the change plan over and over again by asking what is working, what's not working, and what are the benefits of this. So they just started their behavior, and we want to help them continue it, reminding them and normalizing that minor lapses are part of the process. You're learning what plan works best for you. So we focus on successes, reaffirm their decisions, reminding them of their decisions. This was part of the issue for the motivational interviewing in diabetes research study, that the patients came in 3 months, 6 months, and one session where they were able to reaffirm their decision for making this change plan. Help them. And if there's minor lapses, we talk about some options. In the maintenance stage, change is new. They've been doing it for several months now. And these new behaviors have begun to replace the old behaviors. And so they're already establishing this. So we want to support them in the process, just reminding them that. When a crisis and relapse happens, going from maintenance to relapse stage, we explore what were the causes, what were the factors precipitating and maintaining the crisis. And we talk about feedback for the plan, always holding empathy and reminding them this is just a natural thing. We don't cajole them. We don't start to argue. I know you relapsed, but you can do it again. We want to make sure we don't do that. Before I go over the practices and reflections for this week, I just want to remind you to avoid the traps of arguing. And there are several that have been written down in different textbooks. In the article of Brief Motivational Interviewing for Healthcare, they provide 11 of them. They talk about don't order, direct, or command, where we would say don't do that. You really need to. I don't hear students or practitioners doing that. Warning or threatening can happen in, if you don't do this, this is what's going to happen. Now you can ask them, if you don't make a change, what do you think will happen? But we don't say, look, if you don't do this, you're going to die. Giving advice, making suggestions, providing solutions, we want to avoid doing that. We don't argue or lecture. We don't moralize, preach, or tell them what their duty should be, what they should be doing. Watch out for judging, criticizing, blaming. Also avoid agreeing, approving, and praising. And I don't mean it in the Carl Rogers way of praising and prizing the patient, but agreeing in the way of saying, that's what I would do. Yes, that's the right thing to do. Again, we affirm, but we don't cheerlead. Just a few others. We don't shame, ridicule, label our patients. We don't interpret or analyze. And that example would be, do you know what your problem really is? I have said to patients, well, that sounds like the problem. We say these things invitationally to get their response. Sympathizing and consoling the patient, where we say things like, oh, don't say that about yourself. Oh, it's all going to be okay. To reassure them in that way, we don't know if it's all going to be okay. And by changing the subject when they're talking about something important, withdrawing, distracting, let's talk about that some other time. I may have said this in one of the classes. When you want to clarify a point or when you want to change topic, it's useful to say to your patient, I hear what you're saying. I want to get back to that, but I do want to clarify some of this information before we move on. That simple statement demonstrates to them that you care, you empathize, and that you are following the conversation. So please think about that as well. So, practices and reflections for this week. Again, identify the stage of change for your patient. What's the problem or issue, and what's the behavior contributing to the problem, so then you can identify the stage. We're going to continue to express empathy. And for the rest of the time, can you identify the language of your patient and respond to it and evoke it in a proper way? Notice how that goes. Are you hearing affective or cognitive recognition? Are you hearing disadvantages, advantages, optimism, and intention? And moreover, how are you creating a treatment? Same thing as change plan with your patients. This is probably the most important thing for me as a naturopathic physician. How are you presenting your treatment plans to your patient that are in the spirit of motivational interviewing? So thank you very much for listening to this third installment, and may you go gently, knowing your goodness.